just as it is rare to rain here in Arizona, which is actually happening today as we speak, it is also rare for Medicare to recognize the extra work effort required to care for patients with complex and/or serious conditions. It would be a shame for qualified healthcare professionals, physicians, and nurse practitioners and PAs to miss out on the opportunity to be more appropriately remunerated for her efforts in caring for patients. In this video, I will discuss G2211, the HCPCS code that is now being paid by CMS, also known as Medicare, and its appropriate application. Now, this information is based on my interpretation of the House Resolution and Federal Register and will be relevant to anyone, including the urology team members, who wants to use G2211. As always, discuss with your in-house counsel and in-house coder and biller for additional information and further verification. If you're watching this on Facebook Live, I would love any comments, and I would love the opportunity to interact with you. And if you're watching this on YouTube, please leave any questions or comments in the comment section. For those of you who do not know me, my name is John Lin. I'm a urologist in Gilbert, Arizona, also your humble host of the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit, and it is all for free as a way for me to pay it forward to those who are following my footsteps, following our footsteps, so we can benefit the entire medical and urology community. All right, let's get into it. Recently, I released a video in this Facebook group and also on YouTube regarding G2211. If you want an a little bit more in-depth dive regarding the actual publication and the source of where I'm making my claims, please seek that video out, and I'll put it in this area up here, this link up here if you're watching this on YouTube. Now, if you're wondering, where can I find the original source document regarding G2211? Well, that will be HR 1784-F as in Frank, pages 428 through 445, only about 30 pages. G2211 started as a HCPCS code back in 2021, but at that time, it was not being paid because there was a moratorium on CMS making a payment on this code because of Consolidated Appropriations Act 2021. It is G2211. It is an add-on code. So you may be wondering, what is the definition of G2211? And everything that I'm going to talk about refers back to this, so make sure you understand this particular portion. G2211, and I quote, is visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services and or with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. And this is my interpretation here. For most urologists, for most specialists who are non-primary care, this portion, with medical care services that are part of ongoing care related to a patient's single serious condition or a complex condition. This particular portion is what most likely applies to the non-primary care specialists who will be using this code. You may be wondering, to which insurance does this code apply? Well, as of this recording, about a week after the code became into effect, this is being recorded on January 7, 2024, currently, Medicare and Medicare Advantage plans, so Medicare Advantage is also known as Part C, is actually privatized Medicare insurance. It's not really Medicare, but it is privatized Medicare. I affectionately call it Medicare Disadvantage plans. So it is currently applicable to Medicare for sure and Medicare Disadvantage plans. So some of these disadvantage plans do not allow Medicare do not follow Medicare coding guidelines. And some of these Medicare Disadvantage plans require a Modifier 25 on E&M services that should not need a Modifier 25 when certain procedures were done on the same day as an E&M. And you will be reminded that whenever you use a Modifier 25 on an E&M, you cannot and they should not be using G2211. So your mileage may vary regarding the various Medicare Disadvantage plans when they require that you use a Modifier 25, even though I won't say erroneously, even though they're not following Medicare coding guidelines and they require that you use a Modifier 25 inappropriately, in my opinion, when they require a Modifier 25 inappropriately on an E&M by these Medicare Disadvantage plans, I would recommend that you consider also billing G2211 in that claim and see if that will go through, because they should be following Medicare guidelines, because they should offer the same coverage as Medicare. Now, some may argue G2211 is not additional coverage, but in my opinion, my interpretation, it is additional coverage by Medicare, so it should be followed by these Medicare Disadvantage plans. Okay, should I bill this to my private payers? Some people may ask. And some of these questions came from the Facebook group. I've been talking about G2211 quite frequently since its establishment as far as payment goes. So there's been a lot of questions, and I'm sourcing a lot of the answers from the questions that are being asked. One of the questions was, should I bill this to my private payers? And my answer is, yes, you can try a small batch among your private payers, but most likely they're not going to pay, because the private payers' adoption of the new payment guidelines are going to be delayed, typically by several months. And often, do you think they're going to consider paying extra for something that they don't have to? Most likely not. So I would recommend that you can sprinkle a few claims with G2211 when appropriate and see what sticks. And like I said, most likely they're not going to pay initially. But it doesn't mean that you shouldn't try now and see what happens, and also consider trying later and see what happens, because often they don't follow Medicare guidelines. They often don't follow NCCI guidelines. And of course, you should resort and refer back to your contract with your private payers and see what they will or will not cover, or do they follow Medicare guidelines. Okay, another question. Can I use this only in the private practice clinic, or can I use this in the hospital setting? So this is a little bit nuanced. You can use this code billing for facility and in facility and non-facility settings. What I mean is, if you're in a private practice like I am, yes, you can definitely use G2211. But if you're also, however, if you're employed by a hospital as a urologist and you're billing E&M services in the hospital setting, don't think that you cannot bill G2211. You can bill G2211 because there is actually a facility RVU value associated with G2211 for both facility and non-facility settings. Another question, can non-primary care doctors use G2211? And obviously the answer is yes, otherwise we wouldn't be talking about this for me as a urologist. Another question, can I bill this code alone? And the answer is no. It is an add-on code to office and other outpatient E&M service, so you should include an E&M service with a G2211 and not bill G2211 alone. Can I use this code when I conduct a telemedicine visit? And the bottom line is yes. So far, so good. 99441 through 443. You should be able to code and bill for it. We will see what your Medicare administrative contractors do if they're actually following the guidelines. But yes, you should be able to bill for telemedicine visits with G2211 when appropriate. Can I use this when I code an E&M service with the Modifier 25? As I alluded earlier, no, you should not be coding and billing G2211 whenever you send a claim out, an E&M claim with a modifier 25. Questions arose, and this points to misunderstanding and misinformation out there among urology practices. In the Thriving Urology Practice Facebook group, when I posted about G2211, a urologist asked, hey, I'm coding Uroflow, CPT code 51741, with my E&M. And whenever I code a Uroflow 51741, I use modifier 25. So does that mean I'm excluded from G2211? Yes, if you erroneously use a modifier 25, whenever you use a Uroflow code, you won't be able to use G2211. However, you are wrong in using modifier 25 whenever you use 51741 or Uroflow. Furthermore, if you do a Uroflow, commonly done by urologists, if you do a post-void residual by ultrasound, CPT code 51798, those codes should not require a modifier 25. And you may be like, what? Yes, that is correct. 51741, Uroflow, 51798, post-void residual by bladder ultrasound do not require a modifier 25. These codes have a global indicator of XXX, which means the global concept does not apply to these codes. Even though you may have been misled, misguided, misinformed regarding the need to use modifier 25, you should not use modifier 25 for Medicare patients when you bill and code for these codes. Now, that said, private payer rules may vary. Private payer rules may vary. If you have to use modifier 25 for those CPTs to get your claim through with a private payer, in that situation, I would break the glass and say, hey, I'm going to also try G2211 because the payer is erroneously forcing you to use modifier 25, and that is not following the Medicare guidelines. So that is something that you all need to be aware of as urology practices. What about evaluation and management service provided in conjunction whenever you provide an LHRH agonist, such as Trelstar, Campsevity, Lupron? This is a little nuance. Even though LHRH administration 96402 has an XXX global indicator, apparently NCCI requires a modifier 25. So unfortunately, in that situation, you will not be able to use G2211 whenever you administer Trelstar, Campsevity, Lupron, etc., an LHRH agonist using 96402 with an E&M service. Now, that should not be with every LHRH administration that you're using an E&M service, but I'm not going to digress into that discussion. We'll stick with G2211. Okay, next question. Can I use this code when I code an E&M service with a modifier 25 or another payment modifier? And my answer to this will be maybe, or a soft no, soft yes. I refer back to HR 1784F on page 429. And I quote, while we did not explicitly prohibit billing the office and other outpatient E&M visit complexity add-on in conjunction with visits that are reported with various modifiers, we stated we did not expect the add-on service to be reported for visits billed with a payment modifier, for example, to identify a separately billable E&M visit in conjunction with a minor procedure. Open paren, 85 FR 84571 through 84572. We stated that visits reported with payment modifiers are likely to involve resources distinct from the standalone office and other outpatient E&M visits for primary care and other longitudinal care or complex patients, and that we may consider this issue in future rulemaking. Okay. Now, when they refer to 84 FR 84572, 85 FR 84572, Federal Register Volume 85, number 248, dated December 28, 2020, or FR document number 2020-26815. Yes, I actually looked it up when they referred to that particular document. And I quote, while we would not expect that G2211 would be reported when the office and other outpatient evaluation and management visit is reported with a payment modifier such as a Modifier 25, we are not establishing any policies that prohibit reporting the add-on code under those circumstances. Did you get that? I'll read this again to you. While we would not expect that G2211 will be reported when the office and other outpatient evaluation and management visit is reported with a payment modifier such as a Modifier 25, we are not establishing any policies that prohibit reporting the add-on code under those circumstances. So there you go. That's why I say maybe. And in my practice, I plan to use Modifier 24 with the G2211 when appropriate. So you take it as you wish after reading this. And if you want, you can read the Federal Register and the House resolution to satisfy your curiosity. Another question. How much does G2211 pay? It pays $16.04 nationally. Now, this, of course, is subject to GPCI adjustment depending on where you practice. GPCI is Geographical Practice Cost Index, and it varies depending on where you practice, and your Medicare administrative contractor will make those adjustments for you. It also has a work RVU component to it. It is 0.33 work RVUs and 0.49 total work RVUs in the facility and non-facility settings. The work RVU component calculation is important to those urologists and physicians who are employed or hospital employed, etc., and you base your compensation partly or totally on work RVU production. So whatever, first of all, you should use this code when appropriate. And number two, you should account for this code in your compensation calculations if work RVU plays a role in your compensation. And make sure that your employer, whether that's a hospital or private entity, is accounting and adding this in your total work RVU production. Very, very important. Another question. Do we put the fee, the code and the feed and the work RVU in our practice management software solution and charge it, or do we simply let CMS, Medicare, pay whatever they want? And my suggestion is that you activate the code in your practice management software, just like any new CPT code that comes through the AMA, etc. Add that code to your practice management software, add the amount that you would charge if you were a private practice to a private payer, enter whatever that charge may be, whatever X multiplier of the poor payment from CMS. Most practices use a multiplier, and I'm not going to recommend a particular modifier because that may be seen as collusion, and I don't want to do that. So you would activate the code in your practice management software, include the fee amount for your practice, how much you want to be paid extra for that code, enter that fee in your practice management software, and make sure you include the work RVU amount and the total RVU amount, practice expense amount, and the malpractice expense amount. Include all that in your practice management software, just like any new CPT code. Next question. Can an advanced practice professional, advanced practice provider, such as a nurse practitioner or PA, use this code in an incident to evaluation management visit? And the answer will be yes. Can the APP use this code outside of the incident to E&M visit? And the answer will be yes. Can this code be used by a qualified health professional, physician, or an APP in the practice, or is it going to be NPI specific? The answer is any qualified professional in your practice. And keep in mind, Medicare is going to look at your practice, your entire practice, as a single entity. So if Dr. A sees the patient that has the single serious and complex condition, and you take over care or you are continuing the care of that particular urologist physician in your private practice, that second physician taking care of this same patient with this single complex or serious condition may use G2211 as well. Can I use this code for new and established patients? And answer is absolutely yes. According to 85 FR 84571, and I quote, "We are confirming that HCPCS add-on code G2211 can be reported for both new and established patients." Can I use G2211 in a post-op visit whenever you code a post-op visit using 99024 within a global period? And the answer, unfortunately, is no. 99024 is not considered an office or other outpatient evaluation and management visit, so you will not be able to use G2211 in a post-op visit. All right, how often can I use this G2211 code? Currently, there is no frequency limit, such as once a month, once a quarter, once a year. There's no frequency limit regarding G2211. So basically, you can use it with every applicable evaluation and management visit whenever you see the patient. Someone in the Thriving Urology Practice Facebook group asked, if I have a patient with metastatic prostate cancer that I'm managing, and the patient is also seeing medical oncology for androgen deprivation therapy and radiation oncology for radiation treatment for oligometastasis, can all three of us bill G2211 specific to the diagnosis of metastatic prostate cancer? Or do we try to build this code to different diagnoses? The answer is this: whenever you fit criteria for G2211, you should bill for it. So I'm making a lot of assumptions in answering this question. The urologist who is taking care of the patient overall definitely should bill G2211 regarding prostate cancer. The medical oncologist who is taking care of this patient, most likely for the long term, because this is a metastatic prostate cancer, seems aggressive, the medical oncologist most likely will also be caring for this patient in the long term. However, that radiation oncologist is usually just treating the oligomets, if not the primary cancer, and that interaction is not going to be long-term, and that relationship is most likely not going to be long-term. And I refer you back to the initial video that I made, and I'll link it in the video description, where I went into detail regarding how it is the relationship between the practitioner and the patient that is very important when using G2211. So I'm making a lot of assumptions here. The radiation oncologist may be iffy in your situation, given the limited amount of information that I have from this question. So GU, urologists, and medical oncology most likely will satisfy criteria to bill for G2211. However, medical oncology may be iffy if there's no long-term relationship. All right, and you may be wondering, how often, what is the initial utilization? How much does CMS estimate that is going to be the initial utilization of G2211? And that will be around 38% for the first year, this year, 2024. The long-term anticipated utilization by CMS when fully implemented will be around 56%. Federal document. In one area, they said 54%. In another area, they said 58%. So I'm giving you 56%. Another question asked in the Thriving Urology Practice Facebook group: how do I document a G2211 visit? And I'll refer you to 85 FR page 84571. And I quote, "We discussed that we would expect that information included in the medical record or in the claims history for a patient/practitioner combination, such as diagnoses, the practitioner's assessment and plan for the visit, and or other service codes billed could serve as supporting documentation. And that is a quote directly from the Federal Register. And in the way I'm thinking about implementing this is that whenever I code a visit with G2211, and I've included in my short drop-down list, my short quick list, and actually that item G211 is not even shown to me unless the patient is 65 and greater, because most of the Medicare patients are 65 and greater. Yes, I do understand some disabled patients also qualify for Medicare, but in the way I set it up is that 65 and older, it'll show up in the current iteration on my short list, on my drop-down list. Whenever a qualified patient is on my encounter, that code will be shown to me. I will sometimes at the beginning of the day look through my patient list and see who may qualify. Whenever I click on G2211, it will say, and I quote, "Evaluation and management visit today is associated with current or anticipated ongoing medical care services related to a patient's single serious condition or a complex condition." End quote. Also, in addition to what I stated just now, I will include in my encounter documentation regarding the follow-up, establishing that relationship that I have with the patient, and also the assessment and plan regarding establishing the long-term relationship with that patient, the continuing relationship with that patient regarding that particular condition. Not necessarily diagnosis, but condition. And I'll expound on that a little bit more. So it may be important for you to document that the patient is to return for follow-up. And really, this is as per routine, right? When you encounter, when you document your visit note with a particular patient, typically, if you're doing things right, you would document when the patient should return for follow-up. And if you don't believe me, you can discuss this issue with your medical malpractice insurer, and they will advise you that you should document the frequency of follow-up and the timing of follow-up, when to follow up. So you should already be documenting that the patient is to return for follow-up if the patient is to return for follow-up. That should be routine. So that should not be any extra work for you. And I'll give you an example regarding documentation for G2211. And in this example, the patient has acute renal colic due to an obstructing ureteral stone with hydronephrosis. Now, that acute ureteral stone in this novel stone former may not qualify for G2211, assuming this is a Medicare patient, of course. But his history of bladder cancer that you are following with surveillance cystoscopies in the same patient. So this patient with new renal colic from ureteral stone, you've been following for bladder cancer or history of bladder cancer, and you have scheduled him for routine surveillance cystoscopies. He comes in with acute renal colic from a ureteral stone. Same patient with two different diagnoses, two different conditions. For the acute renal colic, most likely you're not going to be able to qualify for G2211. But that bladder cancer that you're following for the patient would clearly, most likely, qualify for G2211 because it is a single, serious, or complex condition that you're following, and you are maintaining that relationship with that patient that would encourage him, that maintenance of that relationship, your relationship with that patient would encourage compliance. And that is really the spirit of G2211. Why you're getting paid extra for G2211 is to make sure that the patient follows up so that he or she would decrease utilization overall for the Medicare system. You're being remunerated for maintaining and establishing that relationship so that you would end up making the patient cost the Medicare system less money. So although the acute renal colic from the ureteral stone would not qualify you for G2211, the care, the continuing care of that patient for bladder cancer would qualify. So ureteral stone and your assessment and plan would be maybe ureteroscopy, laser lithotripsy, etc. I would not put G2211 under acute renal colic. Instead, I would put G2211 under maybe history of bladder cancer or bladder cancer of anterior wall, posterior wall, lateral wall, etc. I would put G2211 under that diagnosis. And you don't have to address that bladder cancer at that visit, but I would document patient to follow up as per routine for routine surveillance cystoscopy or whatever the plan may be for bladder cancer. That is where I would put G2211. So hopefully you understand the nuance there in this specific patient example with an obstructing ureteral stone and a novel stone former in this Medicare patient who has a history of bladder cancer that you're performing surveillance cystoscopies. Coming to an end here, so bear with me, just a few more points. Someone's asked, should I start using G2211 now or should I wait until further clarification? And my opinion is that the guidance is pretty darn clear. I've done the interpretation for you. Obviously, you can ask your in-house counsel. You can ask your in-house coder and biller. I'm not a certified professional coder. I just read, educate myself, and I just play a coder on Facebook and YouTube. So ask your qualified professionals for additional clarification, but in my opinion, based on my interpretation of the Federal Register and the House resolution, you should definitely start using it now because the rules are fairly clear to me. Logistically, from a workflow perspective, who should document, record, and report G2211? And my opinion is that the qualified healthcare professional whose National Provider Identification Number, NPI number, is going on the claim to Medicare should definitely be doing the recording and provision of this code in your E&M visits. And you should do that before you sign off on a chart. And actually, the first clinic day that I had forgotten, or maybe the second clinic day, I had forgotten to include the code among my qualified Medicare patients. I had to go back and inform my coder that, hey, I made an addendum and make sure you attach G2211 to the applicable Medicare patient for the E&M service, which was applicable. Okay, 2 more points. For which urology situations can I use G2211? This is going to be very important. And of course, this is my interpretation and my opinion. Okay. If you, the qualified healthcare professional, are doing the management, are establishing this relationship with the patient, and you are managing a single serious or complex condition, in general, this is a generality. You should not say, oh, Dr. Lin says that elevated PSA I should use G2211 for all elevated PSA. The answer is absolutely no. You need to understand the rules of G2211. You need to understand what part of the definition applies to you and your encounter today, and never base the application of G2211 solely on a single diagnosis. It is actually the condition and also the relationship. You need to understand that. So in general, this is a generality. Elevated PSA, recurrent urinary tract infection, a Bosniak 2F as in Frank renal cyst, cancers that you are managing or history of cancer that you are following, urinary incontinence, BPH with obstruction, recurrent urolithiasis or history of urolithiasis. And once again, I'm going to reiterate and emphasize that it is the relationship that you have with the patient that matters as much as the condition and assessment and plan that you have put in place to care for that patient. It is never a single diagnosis which drives the application of G2211. I hope I can. It is absolutely important that you understand this. It is the relationship and the condition not the singular diagnosis. Not the singular diagnosis. Okay, on the contrary, can you use G2211 on initial visits for BPH? And I just mentioned that BPH is one of the things that you can, right? So yes, if you meet the criteria that you plan to establish a long-term relationship for this single serious condition, then yes. That said, the answer will be no. If it is for a second opinion, and I get that quite often from local urologists, patients from local urologists, for whatever reason, the patient is not happy with the care that they've received there, and they are coming in to see me as a second opinion. When I see the patient as a second opinion, whether that's BPH, stones, elevated PSA, recurrent UTIs, history of bladder cancer, it doesn't matter what the diagnosis is. If it is for a second opinion, and I'm not going to continue to care for that patient, and I'm sending the patient back to the primary urologist outside of my practice, which happens frequently, then the answer will be no. You cannot use G2211 in that situation. And that is why I say you can never use a diagnosis as the stipulation for using G2211. It is the overall relationship and also the condition of the patient that you are treating that dictates whether or not G2211 is applicable. Okay, that said, let's talk about some of the urologic conditions or situations that you should not use G2211. Novel stone former with acute symptomatic ureteral stone that you plan to treat and you don't plan to follow up in the long term. You should not use G2211 in that situation. Another one, acute urinary tract infection in a female that is a new patient to you without any history of recurrent urinary tract infections. You should not use a G2211. Now, that said, if the patient is coming to you for recurrent UTIs that has been ongoing for several years, which is typically how the patient is coming to see me because of recurrent UTIs that's been ongoing, refractory to conservative treatment, and now has a recurrent active urinary tract infection, and I plan to care for this patient and keep her out of the hospital with that long-term relationship with this chronic, single, serious, and possibly complex condition, then G2211 may be applicable for this new or established patient. Another situation, if this is a new patient with acute onset epididymitis, which usually is self-limited and is not a recurrent problem, then no, G2211 should not be used. If this Medicare patient is coming in for an epidermoid cyst or a benign scrotal wall mass, that's most likely not going to be a long-term problem, then no, I'm not going to be using G2211. This is not going to be not going to be a single serious or complex condition. Erectile dysfunction, most likely not a single serious or complex condition, unless there are mitigating circumstances. Similarly, hypogonadism or low testosterone. Unless there are mitigating circumstances, I personally do not think that this is a single serious or chronic condition for which that relationship will decrease Medicare hospitalization, ICU admission, etc. So, sorry for the long video. After viewing this video, do you plan to use G2211 in your practice starting tomorrow, which will be Monday? What are your thoughts about G2211 and what additional questions do you have regarding G2211? I would love to hear from you in the comments. And if you're watching this on YouTube, please like and subscribe to the YouTube channel. And as always, I welcome any comments below. Let me take a quick peek over here to see if there are any questions. Someone asked, can you use this G2211 with telemedicine audio only? Yes, I did cover that in this video. So look up there, and the answer is yes at this time until Medicare revises its policy and provides further clarification. There are interpretations that are made in this video regarding HR 1784 and also the final rule that came, the 85 FR that I mentioned in this video. So make sure if you want additional clarification and in your personal interpretation regarding the rules, look that up. I made the citations up above. So as always, thank you so much for the privilege of your time. Please take care of yourself and take care of each other. Thank you. Bye-bye.